So Heidi talked to us a little bit about the public policy and local policy environment and how to use the politics of the place. Mark is obviously in a very political place in the Chicago Public Schools, and how they are approaching that and approaching the role of the setting. I think Sue Thau, who's next, will take us another step. Sue has a degree from Cornell and from a master's degree from Rutgers. She's a public policy consultant for Community Anti-Drug Coalitions of America. She reminded me that she worked at the Office of Management and Budget at the White House, which is really the center of the universe, where OMB decides what's really going to happen. So, and she has been instrumental in writing a lot of the community drug policy from the federal government's perspective, and we'll talk about sustainability from that perspective. Sue?
Well, good afternoon. I'm really excited to be here. And as an old OMB budget examiner for over 10 years, when I got into the drug prevention field, I said, you know what? I want to develop a program that I could bring to OMB in the Hill that's data-based, that everybody has baseline data, that every grantee collects the same core metrics, so that I can actually be really proud of building something that's going to continue to get funded. So that program is actually the Drug-Free Communities program. And when we came up with the idea for this program, I knew that one, it had to be data-based, that every grantee was going to have to come in with baseline data and be able to show that they could collect the data over time to prove that the program works. So this is actually the most recent evaluation of the program. It's a little hard to see, but the left hand is every grantee in the program from their first report to their last report, and you can see there are major reductions in middle and high school alcohol, tobacco, and marijuana use. And on the right hand, those are the 2013 cohorts. So those are people who were funded between 2009 and 2013. And again, you can see, and this is really hard to see, but the light blue slash marks are actually reductions in prescription drug abuse. Monitoring the future from 2009 to 2013 for prescription drug use in 10th and 12th grade went from, I think it was 12th grade, went from 7.1% to 7%. We have these gigantic reductions in prescription drug use in these communities, in no small part, not just because they're data-driven, but because they use the strategic prevention framework, and they're trained. There is a training component in this program that I had written into the reauthorization, so that every single grantee in year one goes through a year-long training with 3 weeks of residential in-house training to learn not just how to do the strategic prevention framework, but how to operationalize it. And the evaluation of the training shows that coalitions that have been trained in this academy actually get to outcomes much quicker and actually do have population level rates of reductions in substance use in their communities. This is the basis of sustainability. Having something that you can show from a baseline has made a gigantic impact. The second thing you have to do to show sustainability is not just go in with a national evaluation. If you're looking to sustain something in the community, it's not enough to say that you know something works from a big national or NIDA-funded study. You need to prove it works in your community and it's worth being funded in your community. This is Franklin County Communities That Care, and over the 10 years that they had drug-free communities funding from 2003 to 2012, they had major reductions in alcohol, binge drinking, marijuana use, and cigarette use. What I'm not showing you, because I don't have a lot of time, is they also showed major increases in high school graduation rates, bonding to school, and what my talk is going to be on, and I hope I didn't run out of time before I get there, is there's something, and we talked about it a tiny bit before, nonprofit hospitals actually now are required by the IRS to spend a portion of their profits on something called the community benefit. And it's actually a legal requirement for them to do this. And historically, most of what they've spent their money on before the Affordable Care Act was indigent care. But now that supposedly everybody has insurance, they are actually well, first of all, you have to do a needs assessment, which is great for my community coalition people because they all do needs assessments, and as I said, they all have baseline data. So before you get to spending any money, you actually have to do a community health needs assessment. And you have to look at the biggest health needs that are data-based in the community. And the next step is that there's an implementation plan that these nonprofit hospitals have to come up with. And interestingly, community building activities are allowable and funded under this. So they can fund community support. They can fund coalition building. How amazing is that? And they can fund community health improvement advocacy, which you can't fund with federal funding because you're not allowed to sort of advocate or lobby with federal funds. So this is pretty amazing. So Franklin County, the coalition I just showed you their outcomes, they were finished with their 10 years of funding, but they were really smart. They had gotten the community hospital on their board as one of the 12 sectors of their community when they started the community coalition. So at the end of 10 years of funding, not only did the community hospital, they were totally bought in. They had the data from the coalition as part of their community health needs assessment, and they picked up the whole funding for Franklin County for all of the coalition building work, for collecting, continuing to collect the data, doing the backbone support for the coalition, doing the analysis. They actually are funding with scale and scope an evidence-based program, Gil Botvin's program if he's still in the audience. And they're still doing all of their environmental strategies, which is what really got them to their outcomes. They looked at the community conditions that were causing kids to use alcohol, tobacco, and marijuana, and they actually dissected why those problems were showing up in their community, and in a multi-sector approach, went after each of the community conditions that they found caused those problems to be occurring. So it's a great example, and we have a lot of examples of coalitions that are getting their data into these community health needs assessments and are partnering with these nonprofit hospitals to actually be able to get funding. The hospitals don't like to feel like cash cows, so it's a great thing when you have a multi-sector organization to invite them to participate. And I'm going to give you another example before I get to the lessons learned. We have a coalition in Tennessee where neonatal abstinence syndrome is a horrible problem. Again, the community hospital is part of the coalition. So they've partnered with the coalition and did a gigantic focus group, and they actually changed their prescribing practices. They were sending these kids home on methadone, and the parents were actually using the methadone meant for the babies. So they actually changed the prescribing practices, so all of these kids are now sent home totally detoxed. And they've also done a gigantic media campaign with the hospital about not using drugs or alcohol or marijuana while you're pregnant. So anyway, lessons learned, I have 21 seconds. Use the coalition's health sector contacts to actually get your data into the community health needs assessment. Once alcohol, tobacco, and marijuana or other illegal drug or prescription drug data is presented to the nonprofit hospitals, it raises right to the top. It's always one of the biggest issues. You just have to have the data to give them. Use the hospital's contacts to share the value of the coalition, and I'm going to end with the thing about coalitions that's so amazing is because they're multi-sector, you can give the hospitals a seat at the table, but it's also a turnkey strategy. Hospitals don't want to start developing programs or picking a program off a list. They want someone to come in and say, here's the problem, and I know how to solve it, and I can prove that I can solve it because I have the data to show you that over time I've actually done an amazing job solving this problem. I've reduced these rates. Here's how I've done it, and if you partner with us, we can actually take these rates down lower because we know alcohol, tobacco, and drug use are major drivers of healthcare costs. So thank you very much. That's it.